Good morning, everyone. Thank you for joining us for day one of Stroudwater's 2025 Critical Access Hospital Conference. My name is Megan Hazelton, and I'll be your moderator for today's conference sessions. At Stroudwater, we focus exclusively on supporting rural and community hospitals. Our team of former hospital executives, clinicians, and financial experts partner with leaders like you to solve complex challenges. We believe deeply in the power of rural healthcare, and we're here to help it thrive. Before we begin, just a few housekeeping items. Please submit any questions for today's presenters using the Q&A function at the bottom of your screen. We'll address as many as time allows. Additionally, the slides and recording of today's sessions will be shared with all registrants after the conference. We're excited to kick off today's agenda with two sessions focused on growth, quality, and innovation. Our first session today is titled Scale Swing Bed Success, Lessons from a High-Performing Committee. And we're joined by a fantastic group of speakers, including Rosie Hubbard and Heidi Clark from Cox Health, and Lindsay Corcoran, Paula Knowlton, and myself representing Stroudwater. And with that, I will turn it over to my colleague, Lindsay.
Thanks, Megan, and welcome everyone. It's a pleasure to be in front of you today. As Megan said, we're going to talk a little bit about swing bed today for our kickoff session of our CAH Virtual Conference. And before we get started, I do just want to provide a little overview of what we're going to be talking about during this session today. Paul is going to walk through a little bit more about the Stroudwater Swing Bed Quality Reporting Program for critical access hospitals and really just get a better understanding about the background and how the program came about. Then we're going to walk through a few of the results that come out of the Swing Bed Quality Reporting Program. 4 years of really in-depth detail and results for the Swing Bed program. And then the folks from Cox will share a little bit more about their high-performing committee. And then really we'll wrap today's session up with really how do we leverage that swing bed quality data. And before we jump into the session, we are going to launch our first poll. And I'm going to do that right now. So if you could just take a moment, we really just want to get a better understanding about who is in the audience today. So please indicate what facility you are from, if your facility currently operates a swing bed program, and what are some of your challenges as it relates to swing bed utilization. All right, we'll give you 15 more seconds. All right, great. Well, thank you so much for your participation there. We do have a wide range of folks. We have majority are critical access hospitals, if you were interested, and also majority are operating a swing bed program, so you are in the right place. Some of the challenges is the highest one being around patient eligibility, placement delays. We also have, and our runner-up would be around staffing and resource limitations. So with that, I'm going to turn it over to Paula to walk through the background of the Swing Bed Quality Reporting Program.
Thanks, Lindsay. If you could just go to, there you go. So Stroudwater worked with the University of Minnesota's research team back in 2018 to develop the Swing Bed Quality Reporting Program just for critical access hospitals. We also interviewed a lot of critical access hospitals and swing bed experts around how we wanted to do this and what information we wanted to use to build this quality reporting program. So we landed on using CMS's MDS section GG to build out the functional assessment pieces, as well as collecting the same data elements as CMS uses to risk adjust those functional assessment scores. We worked with 114 critical access hospitals across 12 states through 2018 and 2019. It was a one-year pilot project. And out of that project, we did have a study that was published in October of 2019. We got a few results for you to share. I'll share with you on the next slide. So what we learned from the critical access hospitals during that year-long process was they really enjoyed the program. They liked being able to track their quality metrics and see how they were doing. And they wanted it to continue. So we moved on and we made more improvements to the program by making it a full quality assurance performance improvement program for swing bed quality. By adding some additional quality metrics, we improved our data collection process as well as a lot of our reporting tools. And then in January of 2023, we decided, you know what? We had those two options, the original option and then the full quality assurance performance improvement program. We decided we weren't going to do that anymore, and we just gave everyone the full QAPI program. So we eliminated that split. We got great benchmarking, and we have great participation throughout those years, and we continue to offer that information as well. Next slide. So out of that study that we had in October of 29 that was published, it really concluded that the critical access hospital swing beds had very positive outcomes. And it was evidenced by the 30-day risk-adjusted hospital readmission rate being much lower in the critical access hospitals than in the rural SNFs. So it's 13.6% for the critical access hospitals versus 21.1% for those SNFs. Approximately 3/4 of the patients returned to their prior living situation or a more independent level of care after their swing bed stay, and there was substantial average improvement in patient functional status by showing the change in the measure of their self-care and mobility scores. This study, once you receive the slide deck, you can just go ahead and click on that link if you'd like to see the full study. CMS defines 5 key metrics for swing bed quality, and we use that same information in our program. So you get reporting back on all of these measures. The first one is return to acute care from swing bed. These are the unplanned returns to acute, and it's a percentage of those patients that are rehospitalized after a swing bed admission. The second measure is return to acute post 30-day discharge. So we do ask that the hospitals make those phone calls shortly after the 30 days after the discharge date to see if that patient was readmitted to any facility for the same or new condition. And then we give back to you some readmission rates. The third measure is risk-adjusted performance improvement in mobility. So we look at each patient and calculate an expected performance improvement score, and then give back to you those percentages of patients that meet or exceed the expected performance improvement score. Measure 4 is the risk-adjusted performance improvement score in self-care. And again, that is those percentage of patients after risk adjusting if they're above their expected performance improvement score. And then discharge to community. So getting those patients back to their community, and in that we include those that are discharged to home, those to an IDDD, which is the intermediate care facility, hospice, and then home with home health care. The reporting that we have available to you is quite extensive. We have what we call our performance report. That's the one in the middle there. Those are the 5 key metrics. This gives you an opportunity to really let your community know about your swing bed program. If you use this report, you can send it off to your referral providers, and they can provide it to those patients looking for post-acute care. You can get those folks back into their community and into your facility, and really use it as it's a marketing piece for you as well. The other reports that we have available, you have month-over-month trending. So those reports are great when you're working on performance improvement initiatives. You'll be able to track on a monthly basis how you're doing with those metrics. And then we also offer a quarterly report where you can get benchmarking to other facilities within your state that are utilizing the program, as well as to the national median. And I will now turn it back over to Lindsay.
Thanks, Paula. So now we're going to walk through a bit of data and some trending of 4 years of results. And I do want to just recognize the kind of the map here that we have of the participation within the Swing Bed Quality Reporting Program. We cover approximately 26 states with 150 critical access hospitals representing those states. So, certainly east to west, north to south is our spread, and so really great representation across the U.S. Just to highlight some of our 4-year trends, and so focusing on those 5 swing bed metrics that Paula just mentioned is the unplanned return to acute. So we have seen that metric actually increase since 2021 by small percentages, but starting off at 7.3% in 2021, increasing to about 9% in 2024. And from really looking at the data and the information and working with the critical access hospitals, we're starting to see this increase be attributed to the higher acuity swing bed patients. And we are hearing from folks that patients are sicker post-COVID. We're seeing a lot of a higher acuity patient within our hospitals, and that's also translating into the swing bed admission. There's also that pre-admission process. It's are we really looking at our swing bed patients? Are they appropriate? Are they ready for the swing bed program? So maybe some conflicts or concerns leading to that increase in unplanned return to acute. Also, our return to acute care within that 30 days, so that 30-day readmission, that's increased a bit in 2024 from 2023. Again, our critical access hospitals are attributing this to an increase in that higher acuity swing bed patient, or seeing those sicker folks, and then potentially discharging patients a little bit too soon. We're also hearing, we're in some locations, some states, some regions, there are struggling with capacity issues, and that they may be discharging folks a little bit too soon. And that then causes that potential return to acute within that 30 days. Self-care and mobility, both those risk-adjusted scores, we've seen overall improvement over the last since 2022 in both self-care and mobility. It's largely due to a strong interdisciplinary team. We consider implementing and having an interdisciplinary team for your swing bed program a best practice. Improved communication and improved discharge planning. So really getting those patients ready for discharge safely, so then they have, and we see that improvement in both self-care and mobility. And then lastly, of the 5 measures is discharge to community. And I would have to say that this is a really great story to tell, is the higher percentages and the improvement that we've seen in the last 4 years around discharge to community, where the critical access hospitals have really attributed this improvement to improved discharge planning, involving patients and family in that discharge plan, really getting that motivation, establishing that safe return to home discharge plan, and education starting at admission and really educating that patient through the moment of discharge. And so we've seen some really nice results there over the last 4 years. This slide here really speaks to how the critical access hospitals have performed against the skilled nursing facilities. And as Paula mentioned, the original study, we look at it back in 2019, we've re-looked at these key metrics, and we're comparing the swing bed program to the short stay skilled nursing facility metrics. And so that's what you'll see here on this chart, where we'll have the SNF data, which is pulled from Hospital Compare, and you'll see for each of those 5 key metrics, and then the date span in which those those scores were pulled from. And so then we will pull that same date span from our critical access hospital swing bed quality reporting program data to compare that to the skilled nursing facility. So in aggregate, the critical access hospital swing bed patients outperformed the skilled nursing facility on the discharge to their community. You'll see that the CAHs had a 74.2% of patients were discharged to the community versus only 49.9% of the SNF discharges were back to the community. Also, the critical access hospital swing bed program also experienced a lower rate of unplanned returns to acute during that same time span of 8.8% compared to the skilled nursing facilities at 25%. We also saw that 9% of the swing bed patients had that return to acute within 30 days post-discharge versus the skilled nursing facilities, that rate was about 10.5%. Where we saw a lower score, and I say slightly lower score in the critical access hospitals swing bed program compared to the skilled nursing facilities, was both an improvement for mobility and self-care. So those two risk-adjusted metrics. And, I often get the question, well, why is that? Why is that improvement in mobility slightly different than the skilled nursing facilities? And, I would have to say that how folks are risk adjusting can be occurring. There could be differences in how team members score improvement. Again, you score your really understand what that improvement is. And also that acuity of the patient certainly can play a role and a factor in whether or not those scores of improvement are seen. Sicker patients, higher acuity patients may be more appropriate for a hospital-based swing bed program versus a short stay SNF program. So there are some additional metrics that we did also collect through the swing bed quality reporting program. We also, and those will also are compared to the short stay SNF metrics as well. One is around the influenza vaccine. The critical access hospitals performed slightly better than the SNFs. There's also the improvement seen in pressure ulcers and injuries, and that is a new or worsened pressure ulcer or injury. And then also the improvement seen comparative to the SNFs in the critical access hospitals of falls with major injury. And those were better in the critical access hospitals. The SNFs ranked slightly higher than the critical access hospital performance in the pneumococcal vaccine rate, which is seen at 75.4% compared to 81.6%. So with all of that said and all of that data presented, and you can really see where the critical access swing bed program is really very competitive in terms of quality and also can outperform the skilled nursing facilities in terms of patient outcomes and quality. And really the swing bed quality reporting program has tremendous benefit to a hospital's swing bed program. And it allows hospitals and organizations just really start to track and trend swing bed quality data, something that we really haven't done before. We haven't had to do before. There's opportunity now that we're tracking and benchmarking our data is really to set performance improvement goals and to really work towards improving towards a goal. We have the ability to benchmark and compare to peers and like hospital and like skilled facilities, as well as other critical access hospitals in our state, as well as national averages. This allows us presenting kind of quality data and reporting data, allows us to have improved communication across our disciplines within our organization, and the ability to share performance reports with leaders. We really want to make sure that we do highlight the really amazing outcomes that we're having within our swing bed program, and highlight how our skilled nurse, our critical access hospital swing bed programs is outperforming the skilled nursing facilities as well. So with that, I'm going to shift gears a little bit, and we're going to have Rosie and Heidi from Cox talk a little bit about their experience.
Good morning, everyone. My name is Rosie Hubbard. I'm the Admin Director of Nursing at Cox-Barton County Hospital in Lamar, Missouri. We are a 25-bed critical access hospital. We are nationally recognized for being a level 3 stroke center and a top 20 hospital for quality. Fun fact, Lamar is the birthplace of our 33rd president, Harry S. Truman. Both of our hospitals are part of a larger health system, Cox Health. We employ over 14,000 people. We have 5 campuses that span across Southwest Missouri. Our main campus in Springfield is a level 1 trauma, stroke, and STEMI center. The Barton County campus is about an hour and a half away from the Springfield campus. Heidi?
And hi, my name's Heidi Clark. I'm the Admin Director of Nursing here at Cox-Manette Hospital. Our fun fact is we decided to take on building a brand new facility in the heart of COVID, and we moved in January of 21 to this beautiful new facility. We are located about 60 minutes away from Springfield, from our large hospital. And back in July of 23, we were tasked with working on increasing patient admissions, patient days, and revenue in our med-surg departments. And with that, we decided our focus was going to be on swing bed. Stroudwater was offering during that time several educational opportunities around swing bed. And one of them was a Learning Action Network that was a 7-part series that literally helped us to walk through what we wanted to do within our swing bed program and helped us to be able to achieve that. Next slide.
We wanted to make sure we were doing better for our community and our health system by optimizing our swing bed program. However, we knew we couldn't just do it overnight, and we did run into some hurdles. So below are some examples of hurdles. We'll talk about solutions in the next section. Early on, we discovered that not many people knew what a swing bed was. Why in the world choose swing bed? How could we serve our community if people did not know what a swing bed was? We also found that there was misalignment across the system. Not everyone at our Cox Health main campus in Springfield knew that they could send their qualifying patients to our swing bed. In addition, we identified in our committee that both Barton and Monette swing bed programs were the same, but we had different policies and workflows between our campuses. We also wanted to make sure that the system could understand what value we could bring. We optimized our already existing swing bed programs so that we could show how we could benefit the whole system. Lindsay talked about facilities having capacity issues. So we told them, send us your patients that qualify for nursing. It will help decompress your beds. If their patients are post-stroke or MI, it's a possibility that they could suffer from another episode. At our campuses, we could elicit an emergency response team if they did suffer another episode. In addition, if the patient lives closer to their hometown, it will help them to be closer to their home and their family and visitors. Also, we talked to our system representatives about how swing bed can help decrease the readmission rate and how it positively affects our other quality scores that are tied to our reimbursement, like decreased skin issues and decreased falls. We wanted to let our patients know what value this would bring to them as well. So when the whole care team realizes what services and benefits the swing bed program can provide, then we can all work together to make sure that the patients receive the appropriate care.
And like Rosie said, we knew that we could offer great quality care, but how could we market that? How could we have any benchmarking data? Press Ganey was one of our primary surveys that we send to our patients once they're discharged. And a patient being discharged from a swing bed stay did not receive this. So we weren't able to collect that data to show what we could really do to improve their outcomes. Next slide. So with that being said, we decided what we needed was a targeted group of individuals that was all focused on the same goal and outcomes. With that, then we decided that we were going to not only look at Cox-Monette at the time, but that both of our facilities could benefit from growing our swing bed programs. So we established a joint swing bed optimization committee in 2023.
Our multi-D team consists of ancillary members. We knew that to achieve the best outcomes, we would need to engage everyone's viewpoint. In Barton County, our members were all in new positions. Every single one of them had been in their position for 1 year or less. The partnership with Monette campus was crucial to our success. They had members on their team that had years of experience in the swing bed program. Our committee did have team members that spanned across 3+ campuses, so we made our meetings available virtually. In our first meetings, we realized that there were key members of the team that were missing. So we quickly added our swing bed activities coordinator, who plans our leisure activities and helps with ADLs. And our most recent addition has been our advanced practice providers. We also realized the great importance of having system-wide support from the main campus in Springfield, representatives of the ancillary departments that could provide us with more resources.
So in the beginning, our committee met bi-weekly because we recognized we had a lot to go through, starting with our policies. As Rosie mentioned, our policies and processes, even though we were basically identical facilities, we recognized there was a lot of differences. So we went step by step through every policy and procedure, and we aligned them, along with any forms and paperwork that we used with our admissions. We went through an extensive tracking of referrals. Where were we getting our referrals from? Why were they being denied? What was our turnaround time on our referrals? Patients that were using the report, patient days and using the reporting program were things we wanted to focus on. And then educating providers and the community of the benefits of swing bed services. Within our own facility, we recognize that even staff working in our hospitals did not understand what swing bed was, that it was skilled nursing, and when it could benefit either a family member of theirs or a neighbor or loved one. So we started with hospital forums, and we basically talked through what the program was. We took it to our providers. We made sure that they understood how it could benefit the throughput through the ER to getting patients admitted if they were coming back from a skilled nursing release. We talked to our hospitalist about how we could go ahead and move these patients on for further education or continued treatments. And then we decided we were going to take it out to the community. So we started with our board members, and then we moved out to the Lions clubs and the Kiwanis clubs. And we know that we have several other entities that we still need to hit, and we would love to hear at the end if you have suggestions. We're planning on going to senior centers. But marketing is really difficult and a challenge now that we don't have local newspapers and we're relying on social media, and a lot of the older people do not get their resources from social media. Next slide. So with our swing bed committee meetings, we wanted to have an agenda that was targeted to keep us on track. This is just a sample of one of our past agendas. We learned early on that with every topic that we were going to talk about, that we tied a team member to it. That way they knew they were responsible with coming with the data that was going to be reported out. And if for some reason they couldn't be present, supplying that data ahead of time. We went through and we keep an eye on our referrals. We talk consistently about any challenges. We look at Stroudwater data. So with the information that we're entering into the Stroudwater program, this is where we pull up our data and we look at it. We compare ourselves between Cox-Barton and Cox-Monette, but then we also compare ourselves against the state and nationally. Where are we benchmarking and what do we need to have as a target? We look at daily activities on this particular agenda, what we could do to increase it and make it more of a home stay versus a continued acute stay. And then we have action items. These are things we keep on our radar all the time, what we can be doing to continue to bring this out into the community. During this time, we created a brochure that we could take when we went to our marketing events and also to have available in-house. And then we follow this with meeting minutes that has tasks on there with an assigned responsible party that is going to be taking it back on the next agenda and reporting out. So we wanted to make sure that this committee was truly a working group and not just another 30 minutes of somebody's time once or twice a month that we weren't going to be making any progress. Next slide. So I have to say that, you know, our success has really came from the dedication and the commitment of our team of this committee. This kind of sums up everything that we did moving forward with organizing our swing bed committee optimization and what we wanted to work on. But it was the support of our hospital president. It was our system backing us as we wanted to move forward. And it was every employee within our hospital learning and understanding what this program could do and how it could benefit keeping our patient beds full and bringing in revenue. Next slide.
Through Stroudwater, we had a tool that could be used to gather data points, and these are some of our scores.
Yeah, so we were, you know, if you want to know how did we do, well, this is the best way to show it. In 2024, we were able at Cox-Monette to increase our swing bed admissions by 71.8% than what we had the year prior, and we increased our patient days by 30.3%. Our average monthly swing bed admissions in 23 had ran approximately 4 a month. We were up to 20 a month in average, and we hit our record month of 26 admissions. And I think we've actually beat that now with 28 since that time. So our concerted efforts we were seeing results. In October of last year, because we all recognized that if we're going to continue to keep our eye on the ball and we're going to get these referrals done quickly and we're going to continue to understand the regulations and guidelines that surround the swing bed program, that we really needed to have a swing bed coordinator. This would be her primary task. So we put together an SBAR along with a performa and a job description of what we could see the swing bed coordinator doing. And I'm happy to say that we had this approved through our health system. And Cox-Monette now has their first full-time swing bed coordinator that is hired and in training. And Cox-Spartan County just hired theirs and will be starting training in the very near future. We had a utilization review nurse that had also, because of her years of education and familiarity with swing bed, had been kind of our lead as a swing bed, and she was retiring. And that was one of the reasons we knew that we were going to lose that person that really helped to guide and keep the focus on this program. Our use of benchmarking data and highlighting the financial benefits system-wide, of course, is what we used in order to move forward with that and to continue to get investment within our program and our facilities from our entire health system. Next slide.
These are some of the scores that we showed to our team, just to let them know that our data from Stroudwater helps us to guide where we should focus our care. And that our committee actions were actually helping improve our patient outcomes. During our committee, we asked questions like, is our program working as intended? And then we were able to focus in on what can we do to get our specific performance scores up. Next slide.
And I think talking about that and looking at those last scores, we're not overly pleased with the scores that you showed. Can you go back one slide for just a minute? You know, when we're looking at this and we're looking at our self-care and our mobility risk adjustment scores, we feel like this is not truly representing how well we are doing. And so when we talk about some challenges on the next screen, part of it is really understanding what documentation you need to support to show that you are making those improvements. So when physical therapy and occupational therapy, we recognize in the hospital, sometimes they have some lofty goals. They're really wanting to see probably a greater improvement than what we're going to be able to do by the time they're discharged. And so teaching them and helping them to understand that really documenting realistic goals and then helping them to meet them is something we need to focus on. And we reached out, and Paula worked with us a couple times on when we were entering our data into Stroudwater, because we were interpreting what that question was asking incorrectly. And so we really look to see these scores blossom here in the next quarter, now that we've aligned and educated our staff that enter this data as to what that information needs to be, along with educating our PT and our OT, what we need in documentation to support this. Next slide. So data reporting. So when we first started this, it takes time to enter that information into the Stroudwater. It takes time to understand the program. It's ideal if you can have somebody dedicated, maybe one person and a backup person, so that you do understand the information that needs to go in. So, you know, that has been a little bit of a challenge for us, but we're working through it with our support and our partnership with Stroudwater. And we're happy to see our reporting numbers growing. Documentation and scoring. So again, our PT and OTs, they use a little bit of different terminology sometimes than how the Stroudwater is asking or CMS ask for the results. And so that has been an education piece. And then just everybody knows, if you don't keep your eye on the ball, the documentation gets missed. The work is getting done, but the documentation sometimes doesn't get in the chart. And so we've really started some real-time chart reviews to look at our swing bed patients when they're in-house, so that we're not catching this after the fact at the time that we're entering our information into Stroudwater. And it allows us to do that one-on-one education with those nurses and those therapy service staff. And Rosie, you had an interesting thing on documentation and scoring.
Yeah, so during our last two DNV surveys, surveyors were very interested in our swing bed documentation, specifically dental and vision assessments, and then the patient's customary routine. Surveyors wanted to make sure we were assessing and documenting those areas. They wanted to know if our patients had preferences with what their routine and leisure activities were at home. We wanted to make sure that we were providing a home-like atmosphere for our patients and that we were documenting it. So a challenge that we had was just developing and implementing a dedicated assessment in our electronic health record so that we had the regulatory information that was being required from our surveyors. And then we found, when we asked for the documentation change, we found that, oh, it's not just going to affect our campuses documentation, it's going to affect the whole system, some units in which didn't have a swing bed unit. So that was not something that they could accommodate us with. So like Heidi said, we had to start doing real-time audits of just having our nurses document in the record where they could. Without making a final official electronic health record rebuild. So luckily, next year we are moving to a new electronic health record, and we have the opportunity now to help optimize our pre-build so that we will make sure we have a swing bed documentation section.
Yes, so we're looking forward to that. And that way, as regulations change, as there's new things that we may need to focus on, we would have the opportunity, if it is only affecting our critical access hospitals and only our swing bed patients, to make those adjustments that we need. We also have challenges of staff turnover. Everybody knows when you lose our guru, our utilization review person that knew everything from top to bottom, I mean, we recognized a big difference. When she was gone, we noticed we had a decrease in our number of referrals that was coming through because she wasn't reaching out like she was prior. We recognized that we weren't getting to some of the referrals as timely because it was being expected to be done by the manager of the department that was busy during the day and didn't get to it immediately. We've also had staff turnover in our hospitalist program, which is a big obstacle, because if you have people rotating through that really have never worked at critical access hospitals and understand swing bed, they don't recognize those opportunities within your own facility to convert your acute patients over to swing bed and how it benefits us. So that has been constant education. We've also had a turnover of just physical therapy and occupational staff. We had a dedicated PT staff member that was here within our hospital. Now we have therapists that are rotating through. They are our Cox Monette employees, but it's not the same person. So, you know, you're educating multiple people. You think you've caught everybody, and all of a sudden you find that there's somebody that came and provided treatment that day that had never been in the facility before. So that is still a challenge that we work on, and we just have to stay focused. I will say our advanced practice providers at both locations is an excellent resource. They are on Monday through Friday every week, and so they are also helping us to educate our hospitalists. Educating the larger hospitals and the health system on our swing bed program. This is something we still feel we have some opportunities with. Our health system, it is very hard. Like Rosie said, we have over 14,000 employees. When you're trying to get in front of everybody that this could affect, that could help us to grow this program, it's difficult. And what are those avenues, and what is the best way to do it? So we continually work with our hospitalist department up there, with our case management department, with our social workers, having meetings, providing education to them to get to their frontline staff. And, you know, it was a simple thing of a challenge of, we couldn't understand. We know that patients have a choice to come to Cox Monette or to come to Cox Barton County, but our facility was printing off a list of all of the swing bed opportunities and handing it to a patient. Well, this list was a list of skilled nursing facilities, and it did have Monette and Barton. We were at the very last of the list on like page 5. We didn't have any ratings associated with us because we weren't part of that same program, even though we are a five-star quality, 5-star patient experience facilities. And so we had to really work with our health system to say, okay, we understand patients have a choice, but we're not highlighting the benefits and the quality that we can bring to these patients. So what can we do? So we were able to, with our brochures that we have, we were also able to make sure that our names was not the last name that printed off on the list. We could get that sheet on the front since we were the ones that was offering it to the patients. So it's little things like that as far as how are we educating them. And then educating our providers. Like I said, this is probably of the utmost importance when it comes to our internal acute care patients being moved to swing bed. And so this is constant and ongoing. And we look at every opportunity we can share with them. Adding our advanced practice providers to our interdisciplinary team has been a huge benefit in what they can bring to help sharing this news. Next slide. So in summary, you know, we understood that we couldn't just sit back and expect that our swing bed department was going to grow. We had to put the work into it. We had to invest in it. And part of that was forming our joint committee. And a lot of it was our collaboration within our committees, our facilities, our health system, and also Stroudwater that helped us to give us the tools to be able to move forward with. This was just a little bit of the dollar amounts. So in 12 months, we were able to increase reimbursement at Cox Barton by $120,000 and Cox Monette by $200,000. And we expect to see those numbers continue to grow as we continue to look at all of the ways that we can pour into and improve this program. Next slide.
All right. Well, thank you, Cox, for sharing such a great story of one really identifying kind of a problem and an opportunity and really moving through the process of improvement and seeing some really fantastic results. So thanks for sharing. So really just to tie it all together, I really want to touch upon how do we leverage some of this data, this information, really starting off with why does quality data matter? So, when we do collect data and information, that data can support and demonstrate outcomes. We can strengthen our reputation, and we can highlight that we are providers of high quality community-centered care through highlighting our any type of quality data for that matter. And in addition, there are some benefits to that proactive quality reporting. You have to participate in a quality network or a quality benchmarking data collection system, you gain access to invaluable data and benchmarking data. That's where you can start to identify whether or not you are meeting a benchmark, where you're strong, where maybe some of your weaknesses are, and those opportunities for improvement. And then you can utilize that data to tailor that unmet need within your community. How do we enhance and improve our patient outcomes, operationalize and optimize performance, and then utilize that data as a marketing tool? So, but why swing bed quality? Well, we think, the swing bed program is, something that is so vital for critical access hospitals and the patients and the communities in which they serve. And, given that there is a high degree of quality and patient outcomes that is happening within the swing bed program, it is something that must be highlighted. There is no swing bed compare like there's hospital compare, right? And there's nursing home compare. There's nothing that highlights our swing bed program. And, we need to, as Heidi and Rosie mentioned, they talked about patient choice, right? And we know, back in, 2019, 2020, when CMS changed the discharge planning rules and incorporated providing patient choice letters, that did list out those post-acute care providers, and that information listed quality measures and star ratings, things that swing bed programs that are providing the same skilled care as a SNF were not included on those lists. So, it all having that data, being able to tell that story and why swing bed quality does matter. So what are some of swing bed quality goals? What are some of the goals that we would want you to take away as it relates to swing bed quality? And it's really looking at developing a measurement system. Whether it's, through Stroudwater's swing bed quality reporting program or your own, start to develop a measurement system. Look to improve the quality performance of your swing bed program. Understand where you are and establish that goal of where you want to be. Apply some of those best practice quality improvement tactics. What are the same kind of tactics that you apply for improving infection rates in your hospital? Those are the same best practice quality improvement tactics that we want to see come out within swing bed quality reporting. And also establish how you want to improve and sustain results. Where do you want to go? What are those goals that you have, and how are you going to get there? Just to touch upon a few and to leave you with some quality improvement best practices, this really can apply to anything, right? Any quality improvement program that you have really requires a process and a team on board. It's not one person doing it alone, and you really do need to establish that team all working together. Great outcomes don't happen by chance. We don't just kind of throw that sand up in the air and try to figure out where it lands. We have to put the work in. Don't wait for the quarter end to enter data or to look at your data. You need to be making improvements along the way. You need to be looking at where you are in terms of your performance along the way. Oftentimes it's too late to make any improvements when, say a due date comes for entering your data. It's not an exercise to see if you can input data into a program. It's not just a check the box. You're really looking at what can we improve on? Where are we today and where are we going? And then, certainly garbage in, garbage out. If you are putting in bad data or information that is not correct, you're not going to get valuable insights into improvement opportunities or where you are relative to your patient outcomes and quality. Also, again, I would say any kind of quality improvement best practices includes the support from administration. Quality often sometimes is not something that is talked about as often as it should be. It should be something that is supported by administration and the board. We want to make sure that we're discussing quality programs with the staff. So not only is it the quality program that you have throughout your organization, but also share, as Rosie and Heidi mentioned, they share their quality metrics with their leaders, and they start to discuss the quality performance and their patient outcomes of their swing bed patients with staff, really to establish that buy-in, to get that level of understanding across the organization. They look, again, Cox, Monette, and Barton also look at reporting on a monthly basis, understanding where they are and if there's opportunities for improvement. And they establish, action plans for measures that maybe are not within expected results. What do we need to do? They've identified, right? Maybe rehab. We have a different way of documenting. We have a different way of speaking. How can we bring this together to see results and improvement within both our mobility and self-care scores? So we leave you, before we open it up to the question and answer section, is just some key questions to start asking yourself, and as it relates to your swing bed program. When you self-evaluate your swing bed program, why should any hospital refer a patient to your swing bed facility? What makes your swing bed program stand out? Are we articulating the value of our swing bed program from quality data in patient outcomes? Do we know how many patients of ours are discharged home back to their community? What percentage of that? That may be an easy percentage to collect, data to collect, and that's something that we can start sharing with referral sources. Does your community understand what a swing bed program was? Goes back to that kind of marketing and promotion. Articulating what a swing bed program is can be confusing to your community, could be confusing to even your own staff and providers. So do we have a good understanding about what that program is? Are there opportunities to expand your capabilities of services? Maybe we have to kind of self-evaluate and look at, are we accepting the types of patients we've always accepted? Do we have other additional skill sets that we can leverage to then accept additional types of patients within our swing bed program and really look at how we can expand and grow? Are there different barriers or gaps to obtaining our referrals, whether that's internal or external? Sometimes we often hear, it takes us forever, days to get approval for a swing bed patient, to accept that patient into our program. But at that time, we don't have multiple days to wait, or a referring hospital does not have multiple days to wait for you to accept that. They're on to the next referral location. So we really want to make sure that we don't have any barriers that are impeding on accepting a referral. And then how do we measure success? And is our goal to be the provider of choice? And so we leave you with just some key questions to ask yourself as you self-evaluate your swing bed program. And is there opportunities to really optimize your program, layering in some of that quality and patient outcomes data? So with that, Megan, we're going to turn it over to the question and answer session.
Yeah, great job, everyone. Thank you for that great presentation. We do have plenty of questions for you all, so that's great. The first question is for Heidi and Rosie. It is, did the increase in admissions come mostly from within the Cox Health system or from outside your system?
So I can speak to Monette. So a lot of our patients, I would say, was even within our own facility, not even our own Cox Health system. recognizing these patients that we were releasing too soon that could benefit from some education or some additional therapy. And we were also recognizing this in our readmission committees. So we are getting more now, probably from outside resources than we've ever had before. So even like from Barnes Jewish, from KU. So we're getting referrals sent in from other places. And I think that some of that is because our patients are starting to learn to ask to come back here for services that we can offer to them.
And the same is true for Barton County. Yeah, and initially it was inside just because the care team was learning more about it. Oh, all these patients do qualify. So same for Barton County.
Great, thank you both. I have another question for you too, and it is, what is the biggest challenge your hospital faces when it comes to its swing bed program?
So I will tell you, when we wanted to focus on swing bed as growth, one of the first challenges we had to get through was our own med-surg nursing staff, because they were concerned that they were going to be moving away from acute care and starting to care for what they considered nursing home patients. And I think one thing that really helped us was being able to show the quality data on how much better care we can provide these patients than them going to a skilled nursing facility. And also the fact that one of our first growth areas was within our own facility. So these were the same patients that they were caring for the day before with the pneumonia and the respiratory problems. But now we were able to go ahead and help see them and get them weaned off that oxygen and just help to give them a better transition of care to be discharged.
Great. We have a few other ones. How did you get your name at the top of the choice form? Do you use CarePort intake and discharge?
So I don't want to answer incorrectly, so I may have to follow up. I think CareTake was where they were pulling that information from. And basically what we did is we just put our brochure in that on the top of it to go with that list. And then they also were able, because we were at the very back and we were the hospital versus the SNF, I think they just put the page on the top of it and just let them know that we are hospital-based, not skilled nursing SNF. And so that's why we were adding the additional documentation and education about our program.
Great, thank you. And we have another one here. So have you had any resistance from payer who focus on cost per day rather than cost per admission? This individual says we have many insurance companies who are focused.
So I do know that our utilization review nurse and now our swing bed coordinator, that was a lot of the work that she did, is basically as patients were being admitted when she was attending every morning huddle, she was already trying to identify patients that could potentially be a swing bed opportunity within their stay. And so she would already be reaching out, especially to some of our Medicare Advantage plans, and starting to look at what would the requirements be. Do they have any opportunities to be able to stay here? What would they request or require to show as documentation? So she was usually working on this preventatively so that when the provider was said, okay, I think we're going to go ahead and swing this patient, you know, she had a lot of those questions already answered. And so we had less obstacles, I guess, to be able to get over to get them into our program. But yes, we do have some that are very strict in what they will allow or will pay for.
Great, thank you. And I know you all touched on this a little bit in your presentation, but how do your hospitals market your swing bed programs?
So literally right now, it's a lot of it has been word of mouth. Social media, we've done we have a marketing page that we put some patient stories out, patients that have been willing to talk about the care and how they were able to get back to their activities of daily living by coming to our program. And so we share that. but that is a struggle, and we're looking for additional suggestions. Like I said, a lot of the older community is not big into social media. What I would like to see, or one thing that we've talked about, is we are also a level 3 stroke and STEMI center here at Monette. And so we do have patients that, come in here. This is their initial care. We get them stabilized, treated, and then they go on for more definitive care. But if we could catch them in the emergency room, their family members, and just, let them know and recognize that we're so sorry that we can't give them the definitive care they need right now. But if in the future, before they get discharged, they need some skilled nursing, they need some continued rehabilitation, we would love to bring them back home. We would love to be able to care for them here within their own community, and that we have this program. Is there opportunities that we can get information out that way? That is something the committee has talked about. We want to hit the senior centers. We've talked about marketing, even with just our own primary care providers that are within our community, so that they can help to get that education out. So if the time comes, they would know it's an option. Rosie, anything else on that?
Nothing additional.
Great. And you guys both mentioned that you recently just hired some swing bed coordinators who are starting. So what role will those coordinators be playing in managing the care for your swing bed patients? And what will be your average daily census for swing beds that the swing bed coordinator manages?
So I would love for our swing bed coordinator to be focusing on timely referrals. Lindsay mentioned that's one of the biggest things. So they'll definitely be focusing on that. And then the challenges of insurance.
Yeah, the proactive work on helping us to identify which patients, helping to educate our hospitalists that they're working with on the ones that could benefit from it. I think also we would really, this role is going to be entering the Stroudwater data. So that is going to be done on a more timely basis. So hopefully, every couple days that we're getting that information in. We also would like to see them do some marketing, that marketing that we're talking about, going and talking to the discharge planners at our non-CAH hospitals that are around here, that people still, we kind of live in an area, we're halfway between two major hospitals. One is within our health system, one is not. So we have people that literally go to 2 or 3 different places for care. And so taking that out there and marketing, bringing that information to the senior centers, we would like them to be doing that daily auditing on the preferences. Are we capturing the right documentation and helping to educate the nursing staff? And then also working with our outside resources. We find that a lot of our patients struggle with having the home care or the support care when they leave here. And so really working and identifying if there's other opportunities out there, other tools in our toolbox that we can add.
Great. Well, thank you all for today's presentation. We are at time, so we do have some questions or questions that we did not get to during today's session, but you will be getting some follow-up from us with the answers to your questions. So thank you all for joining today. And we are going to be moving on into our second session for the day, which is Thriving, Not Just Surviving, a roundtable on rural innovation and growth. So thank you again to Heidi, Rosie, Lindsay, and Paula for today's presentation, and we'll move on to the next one.